Good afternoon. It's been a long day, so thanks for hanging in. Let's see. Oh, it's backwards. There we go. Okay. Thanks. Good afternoon. So I'm Deborah Ascheim. I'm the Chief Medical Officer for Capricor Therapeutics. And it's an honor to be here to present for all of you today. We're probably the newest on the block in terms of working with this phenomenal multi-stakeholder group, parents and advocacy groups and clinicians and physician scientists, and it is a remarkable group, so it really is an honor. I think I should probably start advancing long before I finish the prior slide. So we too are a publicly traded company. I will be presenting some forward-facing comments, and so I too need to show you this slide. Yeah, that's what I was doing. I could just do it without the slides. But it's not working. How is that? Okay. Stay. Okay, so Capricor is a small biotech company. We have several candidates in the pipeline, and as you can see from this slide, we started by focusing on adult heart disease, advanced adult heart disease. And in fact, it's because of one of you, a mom with a son with Duchenne muscular dystrophy, that we even began to explore using the cardiosphere-derived cells, the candidate drug that I'm going to talk about today, in Duchenne muscular dystrophy. Okay, so the cardiosphere-derived cells, CDCs, you're going to also hear them referred to as CAP1002. We don't yet have a fancy generic name yet, so it's CAP1002. Are derived from donor hearts, tissue from a donor heart. That's allogeneic. That's that phrase that sometimes you hear when you hear about stem cells. It means the cells come from a different donor, not the patient's body. These hearts are hearts that, for one reason or another, are not appropriate for heart transplant, or there's just not a heart transplant candidate that matches to that heart in that region. But even those hearts that may not be appropriate for transplant have an awful lot of viable, healthy, living cells. The cells are manufactured by Capricor in a proprietary process that takes many months, quite some time. They are, as you can see in the little schematic, basically we take the tissue through a series of steps, create what are called cardiospheres. They're little, exactly what they sound like, spheres of cardiac cells, which actually have unique properties that make them act differently than a regular cardiac muscle cell. But those spheres are a little too big to administer to the body. So we need to actually then create a single layer of these cardiosphere-derived cells, the cells that come from the cardiospheres themselves. These cells can then be packaged frozen in liquid nitrogen. It's really cold. And in that state, they can last for 3 years. So essentially, it's essentially like an off-the-shelf kind of preparation, which is very useful when it comes to stem cells. It's much more complex when you're deriving a cell from the patient themselves. The cells were originally invented at Johns Hopkins. So, stem cells. Originally, years ago, when the field started to emerge, and for a number of years, we all collectively thought, terrific, you can get healthy cells that will basically embed in the organ that you are looking to help, to cure, to improve in any case. They would embed, they would disseminate, they would disseminate, and you get healthy tissue. It's just not the way it works. It's pretty clear that that's a class effect. They essentially act as a local drug delivery system. They secrete factors that stimulate the body's own endogenous healing mechanisms. They release a whole host of biomolecules, molecules that your body makes in a healthy state. RNAs, microRNAs, proteins. And actually these biomolecules were secreted within these little vesicles called exosomes. Okay. So the overall effects, and I'm not going to get too specific about the exact mechanisms, because frankly there are many hundreds of them, and that would be a much longer talk. But suffice it to say that there have been a number of, in fact, more than 10, 12 independent labs that have actually corroborated a lot of the data that have demonstrated the effects that CDCs, the cardiosphere-derived cells, have on heart muscle in specific. So, among other things, they induce new heart muscle growth. And again, this is over time. So I should just pause for 1 second to say that stem cells don't last in the body for that long. We know that if they're effective, they are in the body for anywhere from 1 to 3 weeks. That's it. Then they're gone. So they do all of these effects over time, and long after they're no longer there. They prevent myocyte apoptosis, which is basically programmed cell death. It's how the muscle itself dies. They promote new vessel formation. They have active anti-scarring activity. And they attract, as I said earlier, these endogenous, your body's own progenitor cells, early cells that then create healthy tissue. So a number of clinical trials as well and an increasing number of clinical trials as well have now been shown to demonstrate not only the effectiveness but durability of the effectiveness of cardiosphere-derived cells. So in one study, for instance, post-heart attack, and again, these are all in adults, the CDCs were shown to decrease the mass of scar. This also, as you've been hearing a lot about MRI today, this is by MRI again. Increase the amount of viable muscle mass in the heart. Increase the ability that the heart actually can contract. And increase the thickening of the wall as it contracts, which is actually a sign of healthy heart muscle. It's supposed to thicken as it contracts. In advanced heart failure, similarly beneficial effects have been shown with the decrease in New York Heart Association class, which is essentially the severity of the symptoms and the functional impact of the heart failure. A decrease in the size of the heart muscle, the heart dimensions itself, which again is a sign of improvement of the heart. An improvement in quality of life and an improvement in functional status. So the first of these studies that actually showed this in humans was a study called the Caduceus trial, which was evaluating patients after a heart attack. And this was with autologous cells. This was before we moved to the allogeneic cells. So these were cells that were taken from biopsies of the heart after the heart attack, and then processed for that patient, and then returned to that same patient. So there were 25 patients enrolled, 17 of them got CDCs, 8 of them were control patients. They had one single administration of intracoronary infusion of the cardiociliary-derived cells, which means, and I'll show you a schematic of this in a little while, but which basically means that the cells were then infused back into the coronary arteries themselves, so directly into the heart. And basically what you see on the figure to the right is that at both 6 months and 12 months, there was a reduction in the amount of scar in the red bars, which were the patients who got the CDCs, relative to the control patients. And in fact, that the amount of viable, healthy heart muscle increased. Both of these were meaningfully statistically significant changes. Now this is data that's really hot off the presses, and in fact that's part of why it's a lot of words and not really beautiful yet. Really hot off the presses. The dynamic trial, which was looking at patients with heart failure, and for these patients actually this was essentially reproducing the data from the autologous cells with the allogeneic cells. So this is from the donor hearts. So basically at 6 months, and then again at 12 months, and I'll keep this kind of brief because I know we were sort of running behind. We basically showed, again, improvements in, and statistically significant improvements in ejection fraction, ventricular volumes. There was, and at 6 months, in fact, there were statistically significant improvements in quality of life, New York Heart Association class as well. At 12 months, the effect in terms of the ejection fraction, how well that heart muscle was squeezing, sustained, and in fact it continued to improve. So this was actually the first time that level of durability was shown in terms of improvements in heart muscle function with a stem cell. So what does that have to do with Duchenne? So as you all know, patients, boys, young men with Duchenne cardiomyopathy develop cardiomyopathy as well. So the effect that happens with the skeletal muscle also impacts the heart muscle function as well. It's a combination of inflammation, fibrosis, necrosis, dying of that heart muscle function, and it's universal. Everybody gets it. In fact, it is the primary cause of fatality in this group. Hence, this mom coming to sit outside Dr. Morvan's office with a lot of tenacity to get him to actually stop and listen and put the pieces together in terms of the potential logic for what had been shown for scar tissue and for cardiomyopathy that developed after a heart attack, potentially translating to Duchenne. So when Dr. Morvan stopped and listened, he decided to go ahead and actually start to evaluate whether or not this, in fact, the CDCs might actually have an effect in patients with DMD. So this slide basically shows schematically what you know about the progression of heart disease in DMD. That with the figure on the left shows pictorially, essentially, the progression of the amount of scar, and this is by MRI. So these are those T2 weighted images that you saw earlier, but of slices of the heart. And as the delayed enhancement grade increases, that ejection fraction, the ability to squeeze, decreases. And what is remarkably characteristic about patients with DMD is that there really is a linear correlation with age, that the amount of scar increases essentially linearly with time. So Dr. Marban did the first series of tests evaluating the CDC's CAP-1002 in MDX Mouse Model, and basically found that in fact the CDCs were essentially as effective in DMD scar as they were with post-heart attack scar or with chronic heart failure scar. Scar and fibrosis in the heart seems to respond quite similarly. So in fact, on the left, you'll see the ejection fraction in the MDX mice of the control group continues to deteriorate with time. That's the yellow. The red, where they got 2 injections, one injection at baseline and then another injection at 3 months, showed that the ejection fraction went up, at least temporarily, and that, in fact, the second injection, if anything, the ejection fraction, the ability for the heart muscle to squeeze, improved a little beyond what it had with the first injection. That also translated to functional capacity. So the mice, again, you can see the MDX mice who got the placebo, the vehicle, in yellow, their exercise capacity between weeks 3 and week 6 were the most depressed. Those that got this actually is with a single dose of CDCs, were almost twice as much. They were able to walk almost twice as much as the control mice. And then the blue line is the healthy control mice. So we move forward after a number of other preclinical studies and designed the HOPE Duchenne trial, which was designed to support registration for CAP-1002 use in patients with Duchenne muscular dystrophy. It's because this is targeting the heart in specific, that there doesn't appear to be, it appears to be agnostic, I should say, to any of the different forms of genetic mutations. And in fact, in all likelihood, if this continues to demonstrate benefit over time, what we actually envision is that it would be essentially an adjunctive therapy to one of the other skeletal muscle interventions as they emerge on the market as well. We do have orphan drug designation for treatment of DMD as an indication for CAP-1002 right now. So I'm going to pick it up. But this is the design of the HOPE trial. We're targeting obviously boys and young men with cardiomyopathy due to Duchenne. We'll be enrolling 24 patients in 3 to 4 sites. It's randomized 1-to-1 between CAP-1002 infusion and optimal care. And subjects are seeing about 7 visits over the course of a year. There is an open label extension that will start after the completion of a year for the control patients. So just key eligibility criteria. The DMD has to have been demonstrated by genetic analysis. Ejection fraction has to be greater than 35%, and I know that this has been somewhat troubling to people. I think that, because obviously we have to, it requires finding subject patients in a sweet spot. Their heart muscle is affected, but it's not too too terribly affected. Part of the reason, which I'll show you in a minute, is, well, not part, the reason is because of the administration procedure and really needing to have this first trial as a first look at understanding how patients with DMD tolerate a catheterization procedure and administration of the cells via the coronary arteries. Patients have to have at least 4 segments of their heart affected by scar by the MRI. They have to have been on steroid use for steroids for at least 6 months. The first group of patients in the trial, and again, this was really for safety reasons, they were bigger patients that were more used to having catheterizations done, or the doctors at least were more used to doing catheterizations on bigger patients. So the first group of patients had to be 18 years of age. We're now in the second group, so the patients can be 12 years of age or older. In terms of exclusion criteria, we exclude patients if they require general anesthesia for either the MRI or the angiogram. They can't have had major surgery within the last 12 months. Their heart failure can't be so severe that they need some mechanical assistance to help their heart. Kidney function has to be healthy enough, and that's because of the contrast required for the MRIs. They can't have had previous stem cell therapy, and diabetes needs to be controlled. Maybe we don't need to. So basically, they're, in the same way you saw in several other presentations earlier, that MRIs are increasingly being used to look at skeletal muscle. In addition, we're looking at it for those beautiful slices to look exactly at scar versus healthy heart muscle at baseline, at 6 months, and at 12 months. So the infusion procedure itself, patients get conscious sedation. If anything, that basically just means a little bit of a sedative, if anything at all. A lot of the time, the boys have just been lying on the cath table and feeling quite comfortable. It's the same day procedure. You come in, if you can, I wish I had a pointer, but if you see on the body schematic, there are 2 ways that you can get access to put the catheters into the heart. One is through the femoral access area, if you see at the top of the leg, and the other is from the arm. Most patients are being accessed through the femoral area, but part of what we're learning is for some of you and for some of your sons, it's hard to lay flat. So it's a matter, and even for those where it has been hard to lay flat, so far it actually has been doable really without any problem. So we infuse cells into all 3 arteries, and there's an overnight stay. You heard that there's 7 clinical visits, same kind of assessments you've been hearing about for some of the other trials. We're evaluating primarily safety for this study. It's a safety trial, but in addition, a number of functional assessments and quality of life. The first participant was enrolled in February. We are now more than halfway through enrollment for the trial. We've completed the first 2 DSMB reviews, safety reviews of the data, and we anticipate completing enrollment by the end of the 3rd quarter of this year, so end of summer, early fall. As of right now, we're enrolling at 3 sites actively, Cedars-Sinai in Los Angeles, Cincinnati Children's, and University of Florida at Gainesville. Children's Hospital of Philadelphia is also getting up and running. If you hadn't had a chance to get any more information from the booth we had outside, feel free to find me today or tomorrow, or go on to clinicaltrials.gov or our website, Capricor there. It's actually just capricor.com. That's it. Thank you.